Welcome to the Rural American Surgeon. I'm your host, Dr. Randy Lehman, a general surgeon from Indiana. This show is tailored around the nuts and bolts of rural general surgery practice. You will find topics such as practical surgical tips, rural lifestyle, finance, training, practice models, and more. We have a segment called Classic Rural Surgery Stories, where you'll get a feel for how practice in the country differs from the city. If rural surgery is your passion, this show is for you. So, now that the ChloraPrep has dried, let's make our incision. Welcome back, listener, to the Rural American Surgeon today. My guest is Dr. Brogan Bahler, and he's a family practice doctor. Thank you so much for joining us. We're going to be talking today about OB-GYN topics.
All right. Thanks for having me.
All right. So tell us a little bit about your background and your authority to be able to speak on such topics such as C-section before we begin.
Yeah, for sure. Yeah, I have a weird background, I guess, a little atypical for a family doctor. So I guess going back to medical school, I had landed pretty much on thinking I was going to do rural general surgery. So, and during my into my third year, I had my first son. And when I was doing my sub-Is and everything in fourth year, that kind of, I think, changed my perspective on a lot of things in life, and focusing on my family and trying to weigh all that stuff out. And I had one sub-I in trauma surgery, which I really enjoyed, and I really liked all things surgery. And I had one in family medicine, and it was with a private practice doctor, which I think I had like this very, I don't know, like perfect experience with this person that is very hard to recreate. But I think that that's what pulled me into family medicine. And I, had read these stories or heard these things of like the old school family doctors that just were like, did everything. Like maybe they even did appendectomies or they did C-sections. They delivered babies. They worked in the ER. They did all this stuff. And I just kind of decided that that's what I was going to be. And so, with that in mind, I really, really was selective at which programs I was willing to consider and, voiced what I wanted to do long-term and made sure that that was something that they had residents that graduated and were doing similar things like that.
Yeah, very good. So do you feel like you got the training that you needed?
Yeah, I would say for the most part I did. I guess the other odd thing, again, is, I do full spectrum, including surgical obstetrics. And as my career has, progressed, I've actually leaned even more and more into that, where that's my main focus now. But I didn't do a FMOB fellowship, and I was able to, I went to Ball Memorial in Indiana and had a fantastic training there. With my 3 years, I had somewhere around like 300 deliveries, which for family medicine, it's pretty exceptional in 3 years. Mm-hmm. Obviously for OB-GYN, they have numbers that exceed that. But sure. Just a tremendous amount of primary C-sections. And the big thing is that it was really just, all of my surgical obstetrics was taught by MFM and OB-GYN surgeons. And so, they kind of were like, if you're in my OR, we're going to train you like we would train an OB-GYN resident. And if you can't handle that expectation, then you're maybe not cut out for this. And so they had the intensity of a surgery residency, I feel like, within our family med residency.
Yeah. So how many C-sections does somebody need to do to be competent?
Yeah, that's a great question. For a lot of training programs have used either the number 100 or 150. Some of them have tried to steal what is in ABOG, ACGME criteria to graduate from an OB-GYN residency. The hard thing with that is that, I think we kind of do know how many C-sections a OB-GYN resident that is also doing hysterectomies and, oophorectomies and these other abdominal surgeries, how many C-sections they need to do to be competent. But that may not be the same number as somebody that the only surgery that they do is a C-section, if that makes sense, which for most family doctors, they're not really getting into the OR and doing maybe any other surgery other than that. Mm-hmm. So I do think that there probably is a number close to around 150 primary C-sections, obviously not just observing C-sections or It's hard to say with like assisting, how involved an assist is. But I think, when you're doing 150 primary C-sections, most people are reasonably competent to handle the majority of cases. Now, I don't know if that means that you can handle a fourth or a fifth repeat C-section or a BMI, of 60. You're a surgeon, like there's certain cases that when you get out, you're really comfortable with your bread and butter normal cases, but as you progress, even outside of training, I think you get more comfortable with those more complicated cases.
Yeah, that's a great way to put it's a bit of a trap question, of course, because like competency is not a number, right? But how do you determine it? That's one of the things that we have to do. So if somebody wants to do C-sections, sometimes general surgeons in rural areas are called upon to do C-sections, participate in a call pool. Usually they are not at all involved in the laboring. Usually the decision on who the C-section happens to is already made for them. And so it's more of knowing the steps and technically how to do the operation. Obviously, you need to understand the difference between repeat and also someone that's been laboring for a while, also the different presentations. But do you think that 150 C-sections for a otherwise fully trained general surgeon is the right number? Or, and again, it's not a number. That is the trick. But do you think that it's, when you're saying it might be a higher number for a family med resident, should it also be a lower number for a general surgeon?
I think you got to think about the surgery itself and where do you get stuck? Like, what are the hard parts, like the cruxes of the surgery? So, like, you go down through your steps, like, are you going to have trouble getting through skin? No. But like the first area you really get stuck is, with a repeat, lysis of adhesions, those, like, you're going to be fully competent in that with no additional training, right? You're the person that is going to get called in for lysis of adhesions if you're on like the bowel, if you have bowel attached to uterus, like if you, just sometimes it's just one big block of like, it's like, okay, where are my planes? You're not going to need so many C-sections other than like, getting comfortable with the fan and steel approach, like that's going to take 5 surgeries, for you to kind of like know, okay, this is like where we typically do these type of surgeries. Now, the next part of where you get stuck, I would say the most common it would be actually delivery of the baby. And that's going to be the harder part for a general surgeon, I think. A standard breech delivery, it's usually not that complicated, but like you probably do need to see, I would say a minimum of like 5 where you actually have your hands on and do them. And the hard part is even if you scrub into, 30 cases, how many of them are going to be breech? Yeah, I don't know. Obviously that's a standard reason for delivering by C-section in the US at least. We're not doing scheduled vaginal breech deliveries very often. But if it's belly side up, you can have awkward presentations. You can have where a breech that's labored and the feet are in the vagina and the arm presents out and it pops out of your hysterotomy. And now you're like, okay, well, I can't do any of my maneuvers that I'm supposed to do. And so I think in a lot of these things, you can't prepare for everything, obviously. The one thing that I had a OB-GYN once that we were just like stuck in this case where we couldn't get the baby out of a C-section. So, even she'd had enough that the scar tissue is tight, and even with the hysterotomy, and it was vertex, like it should have been easy. And I remember as the resident, I said, hey, get the vacuum. And she just said no. And she J'd the uterus, like big time J, like bandage scissors went up. And she goes, I'm a surgeon. I know how to fix a mom. I don't know how to fix a baby.
And OB-GYN said that?
An OB-GYN did. But the same thing I think for you is like, is your approach maybe going to be a little bit different at times? Like, I think it is. But I think you're probably going to be able to deliver a mom safely surgically, right? But there's probably going to be some things with the baby specifically where you just aren't as, versed and comfortable with as a general surgeon.
Yeah, I think it's a big need in the United States right now. We're losing rural hospitals. A lot of the rural hospitals that are closing do not have they don't have surgery programs. Almost none of them have labor and delivery programs either. But a lot of times what happens is you lose the labor and delivery program. The next year, your numbers look better because you're like in the black because you were losing money on the labor and delivery. But then 10 years later, you pretty much don't have a hospital because you buy the family by delivering their babies. So in rural America, if a general surgeon can participate and can be competent and comfortable helping out with some OB-GYN stuff, including C-sections, it's a huge value. It's also financially valuable. I have done, maybe about 4 weeks or so of locums per year, each year for like the past 5 years since I've been out of residency, which has been kind of really nice to be sort of enlightened and have an eye open and see how things are done in other places. It was also nice because I had a bit of a bug out bag early on when I wasn't sure how. I was kind of stressed out with my practice, and just to have another option. I would encourage anybody. I mean, it's kind of like moonlighting in residency. It's like cross training, because I worked those shifts in the ER in residency, I'm a much better doctor. And I think the moonlighting did that for me, but it just depends what you're going to do. But anyway, my point of saying that is that working for the locums companies, if you're a general surgeon that can do C-sections, that is a super in demand thing.
Oh yeah.
It's not just for locums, it's for obviously permanent positions. Take your pick, name your price and take your pick. I would encourage general surgeons to not be scared of it and try to educate yourself. We'll talk about C-section today. We will also talk about resources about C-section, and if you have an opportunity, if you're still a resident, to go scrub in with as many different people and learn as many different techniques as you possibly can, and how to get yourself out of a bind, and ask those questions and write them down in a little books because you're going to forget, and have that to go back to when the adrenaline's pumping and you're called on to do your first C-section. I just want to encourage, I guess, the rural surgeon in America to not totally throw in the towel on that, because you can really help not just the mom and the baby of that situation, but your whole community, your hospital viability, by choosing, to give of yourself and offer that. And I had one more question for you, because you said just about your background. You talked about how you've went to having a larger portion of your practice be OB-GYN. So tell me how you've done that, and what, I guess, would you do it all exactly the same if you had to do over again?
That's a good question. So I guess I'll touch on a couple of the points that you made kind of and answer that question as well. So going back, I guess, to my training, again, one of the things I did was I did a ton of moonlighting in the ER. A lot. And it was at a single coverage. I actually had privileges at 3 different ERs, but they're all critical access hospitals, all single coverage. Pretty much I only did night and weekend shifts. And so I was the only doctor there. And that was as a second and third year resident. And that was actually one of the reasons, too, that I picked the residency I went to, not just because they allowed it, but that they had mechanisms in place to prepare you before you went out, and make sure that you're going to be able to do that, reasonably safely. And it's weird because, like, going back to that question that you asked about, like, how many does a general surgeon need to do? It's like, well, you wouldn't think that working in the ER would have correlations to me being able to do C-sections, but it does, right? It's like you just get more comfortable, one, with being uncomfortable, two, with handling critical trauma situations. And it also even adds, and like getting back, would I do it the way I did it? No, but is there advantages of the way I did it? Yes. So I'm going to talk on that too. I think that'd be at least something fun to talk about. Yeah. So like, I think that in a postpartum hemorrhage, you have like that OB-GYN mindset when you're thinking like, okay, what are my medications, like my hemabate, my oxytocin, you're thinking about like surgical things like your Bakri, or, a D&C, all those different things, right? Right. So like you have like that mindset and kind of an algorithm that you follow. But then if you've done ER, you also have done ATLS, right? So then you're kind of thinking of like, okay, like your two large bore IVs and like this resuscitation protocol. And you have a better knowledge of blood products, and all of that was beneficial for me, and just having an idea of like a critical patient. And I think in general surgery, you spend some time in the SICU, ICU, and you have sick post-op patients that you take care of. Family doctors, we spend, at least when I was in residency, I had to do 1 month of ICU and then a bunch of months of inpatient hospitalist medicine. But like that ER, actually getting out there and doing it was a huge thing for me. So that answers some of the questions as far as the like, how did I get there? So after I did my 3 years of residency, I gave my, at that point, pager number to every OB-GYN in town. I gave it to every ER doctor and to like 3 general surgeons. And I said, hey, these are the things I want to be able to do by the time I leave out. Page me at any time. Even when I wasn't on call, even if I was post call, sorry if I broke work hour rules, probably not supposed to mention that. But, but I just went in, right? And like some of the things, like you kind of have to say like, hey, it's a 3 years. Like it's not supposed to be a fun time. Like it's supposed to be to prepare you for the rest of your career. And so I had plenty of times that like a general surgeon paged me as like, hey, I have a chest tube. Do you want to come in? It's not emergent, but it's going to be in the next hour. And I would just drive in. And same thing. I had, we actually had a C-section pager that we could ask to carry in the, if there wasn't somebody on at it overnight, they would page whoever had it. And so I frequently was going in at 3 a.m, 5 a.m. to go do C-sections. And then our program was different too, is that if you did the section, you were expected to round on that person until they got discharged, which I was a lot of extra work, but it also, some of the issues with training is like with our work hour restrictions is like you don't own the patient, and so like a lot of times you're not following up with all of that stuff. And so I think got to realize the consequences of my actions, like like those things in the surgery of, oh, like, hey, their hemoglobin dropped. Now what do I do? What I'm thinking through my surgery, like, do I need to get a CT? Do I need to just trim the hemoglobin? All those different things. So anyways, that's a lot as far as just residency, a lot of info. After that, I went on, worked at a critical access hospital in Indiana for 3 years where it was truly full scope. I mean, I pulled some shift in the ER. I was the hospitalist. I had my own clinic. When I was a hospitalist, I would round on everybody before starting my clinic. I also was on 24/7 call for all of my own obstetric patients, did C-sections. The biggest advice I would say on that is don't ask your hospital administrators, is this something I can do? Ask, do you have people doing this currently? And by that, I mean, is like, I have residents all the time, because right now I work with quite a bit of residents. They'll be like, yeah, I talked to this place and they were super excited when I said I want to do all this stuff. And they're like, yeah, we think that like you're going to be able to do all these different procedures. And I'm like, okay, well, who's there doing that right now? Oh, nobody. And I'm like, it's going to be such an uphill battle for credentialing. There's always going to be naysayers. It's just so tough. But the big thing is that, there was a senior physician that was really doing all of the stuff that I wanted to do, that was a family doctor, and he did C-sections, and he was doing, close to like 100 deliveries a year just himself, and did hysteroscopies, D&Cs, ablations. And I said, hey, I want to do this stuff. If I come out here, can I do that? He's like, yeah, absolutely. These are the kind of the numbers we expect. These are the ones I'll help you do once you get here. And so I had mentorship, right? And so like that's important. Also, I had general surgeons where I trained at that were family medicine friendly, that were willing to support me in doing the surgical stuff. And I knew my limitations on when to call them when I was over my head. But generally they like helped me get through the case rather than just taking over and looking down on me for calling them, like, and I think that when you're confident in your skills, like you are more actually likely to call for help when you're over your heads because you're not embarrassed by it. You're like, I just want the patient to be taken care of. Right. And so, like you alluded to earlier, so many places shut down OB departments, and that's what happened where I was at. Is the OB department eventually shut down, and I realized that like that was the portion of family medicine that I loved, and there was other parts that like I did enjoy. It's not like I didn't enjoy, but it, like what can you wake up at 3 a.m. and not be upset about? Like I was never upset to go deliver a baby, but in inpatient medicine, when they called me because there was like a problem with the Foley that like clearly could have waited till like 6 a.m., you're like, oh, why are you calling me? Like, it's just so tough, right? And I mean, maybe it's not for other people, but it was for me. Like, just for me, it was tough where whenever OB called me, I just never was upset. And so there was another community out in Illinois. They had also shut down the OB department. I think it's probably like 5 to 10 years before my transition here. And after that, there was 3 private practice OB-GYNs that quit in that community. And they had one FQHC that had a midwife there that was trying to provide prenatal care for, I shouldn't say trying. She was providing prenatal care to the best of her abilities and really even like beyond, patients that were pretty complicated. And she was like the lifeblood of this community, keeping this prenatal care going so that they could travel to Peoria and then deliver. I interviewed for a position actually to be the director of the OB-GYN department. And at that point, they did have one board certified OB-GYN that was in Peoria, a sister clinic. I moved here and I've been in this smaller town outside of Peoria practicing obstetrics. And when I took over, they did around 100 deliveries per year. The second year I was there, we did 250, and the third year we did 350. And I was able to recruit 2 other FMOBs. So now we have 3 FMOBs. We have 1 part-time OB-GYN that does kind of GYN only, 2 midwives and 1 women's health nurse practitioner. And they're split between 3 clinics. And my main focus, again, I'm half like administrative, but half clinical. And my clinical portion is just 100% obstetrics and gynecology, very minimal primary care. I love it. I've just kind of ended up, but it's kind of weird because like you said, would I do it all over? Well, it's like right now I'm doing all OB-GYN. Like would I have, and there's certainly is headaches with credentialing the way I did it.
Yeah. It would be easier just to do the OB-GYN fellowship. But what's interesting is how you found the thing and how flexible family med is. It's kind of an interesting training paradigm. Yeah.
I view it as like the Swiss Army knife, and you could talk about like the jack of all trades, master of none, but I don't know that that's actually the truth. I think that it's more of family doctors they have enough training that whatever the need of their community is, they can kind of become experts at that. And if you focus enough on that, and that was the thing is that when I was in critical access, doing full spectrum, that was the need of the community. They really needed that. And then I found this community that really needed somebody to focus on obstetrics and gynecology. And my depth of, knowledge in that has just expanded so much over the last several years, to where I'm able to take care of really complicated obstetrics and gynecology patients and have earned the trust of the board certified OB-GYNs at the hospital I deliver at, where they've allowed me to do more and more. And now my practice is really no different than theirs, and with being part of an FQHC, often I'm actually taking care of the most complicated patients with the highest risk pregnancies.
Yeah. And what's funny about that phrase is the full phrase is a jack of all trades is a master of none, but oftentimes better than a master of one. That's actually the phrase. And it's used out of context, the wrong directions, to make it sound like it's bad to be a jack of all trades. But I think that cross training is extremely valuable, and it's relevant to a rural surgeon too, because we're the Swiss Army knife of surgery, basically. So Next question for the show normally is, why is rural surgery special to you? But is there a particular reason that rural OB-GYN is special to you?
Yeah, I think that with rural surgery, obviously there's that community bond, there's a mission, I think there's continuity of care. And that's probably true for all practices that, all different specialties that practice in rural. The scope of practice, I think, is what drew me in that was unique, is that how many level 1 trauma centers are family doctors allowed to do the surgeries I do? I'm doing hysteroscopies and D&Cs, and I'm doing C-sections as a family doctor. I got my wings to do all of that doing rural and through my residency training to prove that I had the numbers. And now I have actually been able to get privileges at much larger hospitals, but it was a huge uphill battle. So I think that scope was one of the things that really drew me to and being able to do the surgeries that I like to do.
Got it. Well, if we don't get to how I do it, we never will. So obviously we're going to do how I do it for C-section. And usually we go into extreme detail about each step of the operation. So starting with the positioning, maybe let's talk about indications for surgery just briefly. The most common indications for C-sections are what? Repeat C-sections and then failure to progress. You tell me.
Yeah, so you have your standard repeats. That as an indication is starting to really change because, VBACs after one C-section, there's some calculators to look at their likelihood of having a successful VBAC. But now there are some institutions that are even doing VBACs after 2 C-sections. So that's a big change. But yeah, for sure, just a standard repeat, very common. Breech presentation we alluded to earlier. Failure to progress or non-reassuring fetal heart tones are your other really common indications. And so, or fetal intolerance of labor sometimes gets used, but that's pretty synonymous with the non-reassuring fetal heart tones.
Where are we at with twins?
So most larger institutions, you can deliver twins as long as your baby A or the lower one is vertex. Even if your second one is breech, many people will deliver. I'm a big fan of those need to be in the OR. So I actually think that the vaginal portion of it, ideally both are born vaginally, but should be in the operating room. Mm-hmm. And so once, you can labor your patient up until maybe they're like 8 centimeters or like close to delivery, but then they need to actually be moved into the operating room for their delivery. That's not like, to my knowledge, a national standard. Some hospitals do have that as a institutional standard though. Mm-hmm. So and then with your second one, some OB-GYNs will choose and feel that it's reasonable to deliver the second one breech after that first one's kind of paved the pathway, so to say. Mm-hmm. I usually will do an internal version. So that means that I put one hand actually in and then the other on the outside and invert the baby to turn it vertex. And in some situations, you do have to convert to a C-section. Even if you get the first one out vaginally, sometimes you have to convert to a C-section for your second baby. And that's why it really needs to be in the OR. There's just enough that can go wrong that you really need to be able to just have everything totally ready. The kit, everything totally open, your C-section case. So
we have a segment of the show called Resources for the Busy Rural Surgeon, but I'd like to just throw it in now because you mentioned the Green Journal and the guidelines that you referenced. Where could somebody find those?
Green Journal, it's like if you're an ACOG member, then mm-hmm. you get it every single month, but then that also gives you digital access to every single publication. And ACOG makes these practice guidelines, and that's generally what like a lawyer is going to reference if you're ever in a lawsuit is like an ACOG practice bulletin or guideline. Mm-hmm. And all of that's accessed with your ACOG membership. You actually don't have to be an OB-GYN to get membership to ACOG. And if you're doing a large volume of obstetrics, regardless of your specialty, it's probably behooves you to, to have it so you can reference those guidelines.
You can't reference the guidelines without the membership.
Not to my knowledge, which is crazy, right? Like mm-hmm. if it's like national guidelines and you can't get them unless you're a member. So it's not the best situation, right there. Because otherwise you're like going to up to date, or you're just like asking whatever local person, right?
Yeah, sure.
And there are huge deviations in local standard of care. So it is always good to know your local standard of care. But for a lot of stuff, your standard definitions, like what is preeclampsia or whatnot, like are going to be on these guidelines and like standard treatments and those things. And so, and they have some specifically like, on VBACs that have come out recently that have talked about like that 2C section. And those are big changes, right? So if it is hard to stay up to date if you're not having a membership, and it stinks because it's expensive, but for me, it's worth it.
Sure. Well, now that you're 100% OB-GYN, sure, especially.
Yeah.
All right. Very good. Well, thank you. Do you have anything else to add to either of those segments?
Biggest thing for me, I would say, is we've talked about the 3 A's before. You and I have, like the affability, availability, ability. Like that's not just with your patients. I think it's also with your colleagues. So biggest thing is like knowing your specialist and your backup and like your safety net and like all those different layers. And that's your real resource, is like knowing all the people and being, affable with them and being available when they need you. And if you're available when they need you, then they're going to be available when you need them. And so that's probably been my biggest, I think, key to success of how I've gotten here, is that like I've just made friends that like in my local network. So like I'm just really good friends with many of the OB-GYNs here where I'm at, and like they've helped me out a lot. And like, when I've been in a tough situation, like they've been able to help me, whether that's by phone or 1 or 2 times, like even calling them to the OR for help, and so that's important. And so, yeah, I think like a mentoringship, like network, and like that's important.
Yep.
And then I don't, did we talk about, I think you said financial corner too. I know we didn't really hit all that.
We got to bounce back. So the other 2 ones are classic rural surgery and the financial corner. So why don't we go financial corner? What do you think, money tip for our listener that you might have?
That's where family medicine actually did win over, which is weird because I think like the stereotype is that, family medicine, like financially, is like the worst decision, or like they're just so underpaid. And it's like, I get it. Yeah. If you do outpatient only and you work from 9 to 5 and you take no call and you work 4 days a week in clinic, you're not going to get paid super great. But the big thing is it's a 3-year residency. So I started earning the income of attending multiple years early compared to a general surgeon, and 1 year early compared to an OB-GYN. So that was huge financially. The other big thing is that like I had time to be able to do moonlighting. So like I made quite a bit more while I was in residency. Actually, the pay for family med residents, when I looked at it back when I went through residency, was actually a little bit higher, just to get people to go in. And I actually had a sign-on bonus for residency. Isn't that weird? Like I think it was like $5,000 or something to go to family med residency. On top of that, in Arkansas, I trained at University of Arkansas for med school. They had a primary, I don't know if it was, I think it was for like pediatricians and family doctors and maybe internists, that you could get a loan that was separate from like the regular FAFSA loan. And it had 0% interest for like the first 5 years. And then it went to whatever like the normal rate was. And so like, it was only for like the first $20,000 or something a year, but I was able to basically do just that for all of mine. So I had 0% interest on my student loans just because I was a family doctor, right? So that's huge financial. And then when you look at, there's a lot of programs like the National Health Service Corps, where I'm working right now. They offer that, and we have a really high HRSA rating. And so pretty much everybody that comes here generally gets that loan repayment. That one is very different because it is actually tax-free. So you get like $50,000 a year, I want to say, but you don't have to pay any taxes on it, which is the only one like that I'm aware of. And that's a big financial, I think that thing that people don't realize and that they don't prepare for is that they don't realize when those get paid off, when they're forgiven, that you have to pay taxes on them when they're forgiven, right? And like people run into big problems with that because they're not prepared for that huge amount on their tax bill. There's also the public service loan forgiveness, or PSLF. There is a lot of, I remember like, I think Colorado had one specific for family doctors. It was like an extra $20,000 or $50,000, something like that, if you came there. And I just got a huge sign-on bonus to be able to do family medicine in rural. And I found that generally speaking, most family medicine jobs have like pretty good sign-on bonuses. And when I've talked to my like OB-GYN colleagues, they're like, what are you talking about? Like, we don't get those. And I'm like, oh, like for family medicine and like, especially rural. And I imagine if an OB-GYN really went rural, they probably would still get it, right? Probably.
Right.
But like family medicine, I don't know like any family doctors that aren't getting some type of sign-on bonus for where they're going. Mm-hmm. And so, yeah, I guess like quick summary was like access to loans and loan repayment services, short residency definitely has benefits, and then sign-on bonuses when you get out. And then after that, you know, if you have an RVU contract or whatever usually the pay per RVU is not like dramatically different from a family doctor to an OB-GYN. And so if you're doing actually the same workload as them, you're actually getting paid the same amount, right? It's just that the reason why family doctors don't always get paid as much as, one, not taking all the call and the workload, but also that they usually don't do the procedures, and procedures usually have a better reimbursement in RVU. Mm-hmm. Well, like I do tons of procedures. And so like, as far as that's concerned, like I've not had a problem where I'm like, feel that I'm just treated terribly financially, you know, like I think that I'm treated fair.
Yeah. Great. That is a new financial tip for the rural American surgeon listener. Do family medicine. That's okay. Basically, you make a compelling argument. I'll give you that much. And I think that there's a lot of ways to kind of get to where you want to go. The other thing that came to my mind is in 2021, with the changes to coding, there's basically a 30% bump in value for all the E&M codes too.
Oh yeah.
So, which blew my mind when that change happened, because all of these clinic-based specialties that are on RVU-based contracts essentially got a 30% bump in their bonus, you know. And how does that, like, I don't know how, I never heard of a bunch of people like having their contracts be renegotiated or whatever, but it is the reality, and it does make clinic relative to procedures more valuable for both the specialist and for the clinic-based person. So,
yeah, I mean that, and then I guess the other thing is that many rural hospitals are rural health clinics, you know, and so rural health clinics and FQHCs actually get paid per encounter.
Yeah, and
so OB-GYN is actually phenomenal for clinic encounters because they're generally pretty efficient, I guess is a good word.
Quick,
and
easy.
So like I mean, a prenatal or a postpartum, if you can get paid the same amount for that encounter as you do for somebody that has like, you know, heart failure, kidney failure, is 90 years old, is like, you know, this like complicated family med patient, if you're getting paid the same amount, or I mean, you may not be, the clinic's getting paid the same amount, right? But that's part of your negotiation, right? You do have to negotiate your contract to get your fair shake of the pie. And usually, like a lot of FQHCs or rural health clinics, they may actually have contracts that are based on the encounter rather than RVU, which that's a whole, I mean, we could talk for an hour just on that about whether that's right or wrong, but you know, they want to have you to have the same incentives as they have, and not, so that way you're not able to game the system. Right. Anyways.
Yeah, no, that's great. Little financial corner for you guys. Did you have a story that was just classic rural surgery? Now, I understand you kind of have you're not really a rural practice. You have one rural clinic now, but your practice is actually quite urban from what I understand.
Yeah, right? It is changed a lot over the years, right?
But the idea behind the classic rural surgery stories is a story that your urban counterpart just wouldn't believe. So really, any crazy surgery story counts.
Well, I can give you one pretty big then from, I'm going to give you two. One's not surgical, but it's just funny, and that's from my time in rural practice. And then one's a crazy surgical story from my current time, actually. So one that I just loved, and this is classic rural medicine, is that I had this like, I don't know, 80, 90-year-old lady. We'll just call her Betty. And she comes in and she's got like
she presented for a C-section.
No, she's like in the office, you know? My she's AMA, right? Advanced maternal age. Yes.
Right.
So, and she's got like the paper with just tons of stuff written on, which she like, I mean, everybody knows how you actually feel. We don't have to say it when somebody has that just huge paper. I mean, it was like filled out, full page. And I'm like, hey, Betty, it looks like you got a lot to talk about, right? You know, and she's like, oh, yeah, I got a lot to talk to you about today, Dr. Bahler. And she's like, slowly, she's like, so how's your wife? And she knows my wife's name, like says my wife's name. And I'm like, oh, she's doing good. And I like give this like little minute long, and she keeps on asking these like more leading questions about my wife. And I'm like, keep on going. And then she's like, in your firstborn, his name is, she knows his name. And I'm like, and then she's like going on about him, right? And then she's like, in your one that you like, you have what, a 3-year-old, right? And you just had a baby, right? And so she's going on. And at this point, it's been like, I'm not joking, over 15 minutes. And I'm like, Betty, I really just appreciate you. Yeah, I'm like, I want to be like, and I said, but you have that list. Can we get to some of that? And she goes, oh, well, that was just about it. And that was her list. She wrote down all of my family's name. She had nothing medical to talk about at all. And I was like, I don't know, like, what do I even do with this? Like, therapeutic counseling? Like, I don't know. Right. So that's great. So just loved it. And that's like the stuff you miss, right? Like, and same lady would like bring me in like blueberry pies and like stuff from her garden. Like that stuff was amazing. So classic surgery story though. So there, like I said, the hospital where I'm at they shut down actually the OB unit here. So there is no OB unit in that rural clinic, but there was a time that somebody showed up in labor, had I think the report was she'd had like 7 prior C-sections. And there was this report that like she had got to complete, so they were having push, but then it sounded like maybe lost station, so baby had gone back up. It was, and they had called multiple OB-GYNs and nobody could come out there. But then EMS refused to transfer because they felt like the patient was too unstable. And so I got a call and just said like, will you come? And they're like, they just said, we have an emergency. It's obstetric. Can you come? And I'm like, okay, I'm coming now. And I just left. I had like 4 people in my clinic waiting on me. And I just left. I didn't even know and I had actually never been to this hospital. I had to put it in my like, hey, Siri, give me directions to this hospital. And I drove there, like pulled in. I just walked in through the ER. And on the way, I called the CMO of like the whole hospital system. And I was like, hey, I need emergency privileges at this hospital. And they were like, yes, you have it granted. And so like I just showed up there and I asked for an ultrasound and put it on the mom. And so it's compounded. She was like under the influence of, and it's like combative swinging. And I put the ultrasound on, the baby's heartbeat's like 50. And I just like instinctively like go to the OR now. And so like I'm like having somebody like basically hold me by the hand, drag me to like where the scrubs are, where I don't even know what floor the O is. I don't know where anything is. And like I get there and I'm like, hey, we need a betadine splash. Like we're going to have to go under general. Then I'm like, do you have a C-section kit? And they're like, no. And I'm like, well, I just need a scalpel, like thinking like legitimately, technically that's all you need. But then as like the case started, I was like retractors, like bladder blade. And they're like, we don't have any of that. And I'm like, Alexis, they're like, all of those are expired and we do not have them. So I'll save the details of like everything that progressed throughout the surgery, but it ended up being just this, like, she ended up having a uterine rupture, and mom and baby both did great. And they're both doing well today. And, so it's just a big case that at minimum, I'd say the baby would have died had I not been called and been able to get there. And maybe even the mom, I don't know what outcome she would have had. And so, that's like the type of stuff that I think the non-surgeon, like those are the stuff that break you. Like, and you're like, this is why I never want to do this. And those are like the stuff for me. I was like, this is why I did all the training that I did and why I want to keep doing it. Right. Like, you're like, this makes me want to do it for another 10 years, So yeah,
what a beautiful story. Case. How many people did you have scrubbed in with you?
A lot. It was like all of the nurses from the whole hospital, I feel like, showed up, right? So yeah, and again,
and then you had anesthesia.
They had a CRNA,
yeah,
and so and the like ironically
wild.
Again, like small town, like again like this rural. So one of the circulating nurses. So I had a patient in Peoria that's laboring, and she like only wants me to deliver. She's 10 centimeters, first baby, and she like progresses to complete during all of this. And they like tell her like, hey, it's time to push. And she's like, well, I'm waiting for Dr. Bahler to show up. And like my colleague even shows up and it's like, well, I guess I'll just stay here till he's available. Cause like, and we obviously HIPAA, we can't tell this patient this information. Well, it turns out that like that laboring patient, it was like her like sister, I don't even know, like was a nurse at this other hospital and is in the OR with me and is like, hey, so-and-so's 10 centimeters and she's waiting for you. Like, and I'm like, oh my gosh, like during all of like to
during
add on
that
top of
same case
during that crazy case.
Oh my.
Yeah. So you asked like how many people were there? Like there was like abundance. There was plenty enough. But like, it's like literally like one of my other, it's just crazy. So, and I probably can't share any more than all of that just for HIPAA because it's like, you get too into the details and it's probably discoverable or whatever. But it was a big case. And I just was happy I could help out the community and that I serve in. Right.
Yeah. So not like what was the baby's name, but what would be a great baby name for a baby that showed up with a rupture like that? Because this is what I heard. I heard there was a baby that was born as a twin that wasn't known about.
Oh, yeah.
And the first baby had some normal name, and the second one was named D''EXTRA, the extra.
The extra.
The extra. So what would be a good baby name for a, rupture? I got one other one. There's I have a farm and I have cattle and pigs and everything. There's a boar in a boar stud, which, that's how they breed with AI and everything, that was born by C-section. And the boar's name is Out the Side.
Out the Side.
Because they did the C-section, so there's got to be some good.
The convertible top, right? Just take it out the convertible top.
Right.
So
the internal explosion.
I don't know. I mean, it's I think just it's being its seventh baby too, right? You could just, maybe that's it right there, 7. Like we just at some point you just run out of names and you start numbering them.
Just number them off. Yeah. Come on. Come on in. Supper time. All right, perfect. Well, this has been a great conversation. Thank you so much for taking us through a important operation for maternal health in rural America, the C-section. Is there anything else that you'd like to share with the audience?
I just appreciate you having me. And I mean, I'm sure we could talk for several more hours, but we'll keep it stopped here at an hour, right?
We'll have to have you back sometime and see if there's anything else that we can chat about. So thank you so much for joining us. And thank you to the listener for being here on this episode of the Rural American Surgeon. And we'll see you on the next show.